Good afternoon, everyone. Welcome back from the week at ASN. For those who had the opportunity to travel to sunny San Diego and present some science and get inspired about our field. We want to also, on your way out, be sure to thank Marissa, who organized a terrific event for Dr. Susan Quaggan, who was honored with a very special Lifetime Achievement Award, the John P. Peters Award. And if you came to the reception, you heard our Dean Nielsen talk about the significance of that award. And today we have another luminary in nephrology who actually trained at Northwestern. Maybe some of you don't know, she went to Northwestern for undergrad and also medical school and represents Feinberg in all that she does. And we're very delighted that she was able to find the time to come visit us today, right after ASN. After finishing her medical school at Northwestern, Dr. Rhee went to Oregon Health and Science University, where she did her residency and chief residency. Already during her residency, I guess the leadership skills were pretty dominant there. And then she ended up doing her clinical nephrology fellowship at the combined MGH and Brigham program and stayed on to do her research training there. Yesterday at dinner, she was sharing that she had to submit one of her early grants several times before she got funding. So kind of forged that persistence and the thick skin you need to succeed in academic medicine. But thereafter, she has been able to rise through the ranks in the University of California system. She's currently at UCLA, professor of medicine at the school there and chief of nephrology at the Veterans Affairs Greater Los Angeles healthcare system. And she takes pleasure in taking care of the veterans, even though the VA system does not provide that much support. I found out she doesn't have an administrative assistant, and despite all of that, she's still able to lead a division and also lead a clinical journal. So she's the first woman editor-in-chief in the Clinical Journal of Nephrology, or CJASN, which is one of the leading clinical journals in our field. So pretty remarkable. And I understand that several people this morning took advantage of the opportunity to meet the editor of CJASN and pitch some ideas for the future, which is terrific. But in terms of the research program, she has focused her program on the intersection of kidney disease, nutrition, endocrinology, metabolism, and has been supported by multiple grants from the National Institute of Health, the National Kidney Foundation, the American Thyroid Association, and many others. She currently has 4 active R01 grants, which is exceptional. And for her research in these areas, she was recognized in 2020 by the National Kidney Foundation Council of Renal Nutrition award named for Dr. Joel Kopel, who's another leading investigator in this field. And on top of all of that, if you think that wasn't enough, she also mentors students and trainees across multiple areas: nephrology, nutrition science, endocrinology, public health, biostatistics, and other related disciplines. And in 2023, she received the Distinguished Mentor Award from American Society of Nephrology. So Dr. Rhee, we're delighted you found the time to come visit us. Thank you so much.
Wow, thank you so much, Dr. Isakova, for your extremely generous introduction. And thank you to all of the nephrology faculty, staff, trainees for your amazing hospitality. I'm so honored to be here. I have so many good memories of Northwestern, as Dr. Isakova shared. And I'm really privileged to get to talk to you about a very clinically focused topic that I feel very passionately about, the role of plant-based diets in chronic kidney disease. These are my disclosures. And as mentioned previously, one of my other major disclosures is that I'm a proud alum of Northwestern University. I spent 8 years of my life here as an HPMA student. And notably, I've actually had many connections with a number of people in this audience and maybe calling in via Zoom over the course of my career. So when I started here at Northwestern, actually, Dr. Battier was one of our favorite teachers in renal physiology. We also got wonderful teaching by Dr. Paparello, Dr. Rosa, Dr. Aya, I believe Dr. Gosain too. And then after, I think, completing my my medical school training at Northwestern, traversed OHSU, then went to Boston, had a chance to meet Dr. Isakova. She was our inspiring role model in clinical research and in clinical nephrology. And then since being in California for about 13 years, I've continued those wonderful connections with faculty at Northwestern. We were privileged to have Dr. Quaggan as one of our distinguished professors in Southern California at UCI. It was such a treat. Had Dr. Lin giving our Renal Grand Rounds, which was a privilege, and Dr. Park as well, serving on NIH panels together. And many other names, I apologize that I may not have mentioned, but it's such a privilege to see old friends as well as new friends at today's visit. So by way of background, as Dr. Isakova mentioned, my research focuses on the interaction between kidney disease and endocrinology and metabolism and also nutrition. Another major mentor I want to highlight, who I first met and inspired my path in research, was Dr. Mark Molich. So I actually originally was going to pursue endocrinology. And how this happened was my father actually almost died twice. He actually had a cabbage complication and had stomach cancer while I was a medical student. And I actually had to take 1 year off between my third and fourth year. And, fortunately, we were so blessed. He survived and he's 83 and very healthy now. But when he finished his, surgical resection and his chemotherapy and his radiation, I came back to Chicago to finish school, and I needed something to do. And I sent a lot of emails out to different mentors, and I was so fortunate to meet Dr. Molich. I just wanted to fill my time. I had no, I think, plans whatsoever to go into research, and he took me under his wing. And I joined his inpatient hyperglycemia management protocol group. We would see all of the diabetes patients on inpatient insulin regimens. I would come in the middle of the night and collect all the blood sugar data, I think, out of the medical records. And even after I started my residency at Oregon Health and Science University, still had the opportunity to publish with Dr. Mark Woolwich. And even after fellowship and as a faculty member coming to Southern California, we've still communicated. So I think without him and other, wonderful mentors at Northwestern and other folks, I think in my career journey, I don't think I'd have these opportunities I would have today. So I want to give a huge, shout out and pay gratitude to all of you. So in addition to having the privilege of working with nephrologists, as mentioned, I work with other multidisciplinary experts and learn from folks in the areas of endocrinology, primary care, cardiology. And as we all recognize with these emerging therapeutics interventions, we no longer work in silos. We really have to work together in a multifaceted approach. So some of the themes that you're going to be hearing from this talk focus on that multidisciplinary angle. And I think because of that, there's a lot of creative products we put together through the years. We're launching some things in the journal. This was a textbook we put out actually with not just nephrology, but endocrinology. Dr. Greg Brent is the Senior Academic Executive Vice Chair of Research and Education at UCLA, former Chair of Medicine at West LA VA. And so we put together this endocrine kidney nutrition textbook. If any of you guys have any scholarly interest, we're putting together another edition, and we'd be happy to invite more authors if any of you guys want to pursue this route. So for the next 45 minutes to an hour, there are 3 main objectives I want to cover during this clinically focused talk. We're first going to review the rationale for plant-based diets in CKD, including the scientific premise for low protein and plant-based diets to reduce CKD risk, as well as current clinical practice guidelines for the amount of dietary protein intake, the type, as well as dietary patterns. We'll then discuss comparing and contrasting various plant-based diets and their potential benefits and limitations of a low-protein plant-based diet, and emerging data on the outcomes of incident CKD, CKD progression, and associated CKD complications. And then we'll close with discussing the practical implementation of plant-based diets in CKD, including common misconceptions, as well as approaches to mitigate potential risks. So everywhere you go, be it the grocery store, be it the fast food restaurant, even Starbucks, you see a number of different plant-based products available. Even Netflix, you can't avoid information about plant-based food. So some of you may have seen the Netflix movie Game Changers, which highlighted ultra marathoners, cyclists, power lifters who consume vegan-based diets and I think attest to their contributions to their physical performance. However, over the course of this talk, I want to take some time to talk about the role of plant-based diets in CKD and try to separate a little bit of fact, from fiction. So starting with the premise for dietary interventions in CKD, each year over 125,000 people transition to end-stage kidney disease in the US, with the dominant proportion of these people initiating in-center hemodialysis. And as we know, dialysis may not always exert the intended effect of increasing life nor restoring health. And there are a number of studies that have shown that incident dialysis patients in certain subgroups may manifest higher one-year mortality rates and lack of survival benefit, frequent hospitalizations and readmissions, lower health-related quality of life, loss of independence and physical function, higher symptom burden, and as well as incurring higher healthcare costs. There have been a number of population-based studies highlighting the early mortality peak that we see in patients initiating dialysis. So that has been seen in LDO data, US DOPS cohorts, and even the USRDS. The dominant proportion of deaths, as we know, are due to cardiovascular causes. So we know that CKD patients have an exceedingly higher cardiovascular risk compared to the general population. And seminal data published by Dr. Lorian Dalrymple highlighted in the cardiovascular health study that older adults with CKD are much more likely to die of all-cause death or cardiovascular death than to even make it to end-stage kidney disease, than to even progress to dialysis. In light of this, last fall, the American Heart Association, with a very nice commentary from Dr. Quaggan at Nature Reviews Nephrology, published a scientific statement on the interrelationship between cardiovascular disease, kidney disease, and metabolic health. And they discussed the existing evidence as well as current clinical gaps and future areas of research in the CKM space. Also recognizing this, several years ago, the White House unveiled the Advancing American Kidney Health Initiative with 3 major goals. And one of those major goals is to encourage the adoption of treatments that reduce the risk or slow the progression of chronic kidney disease. And this has therefore raised to the forefront discussions of primary and secondary prevention of kidney disease, as well as its cardio-kidney metabolic complications. And therefore, we have to think creatively, and we have to use a multifaceted approach in the management of CKD, as well as this cardiovascular kidney metabolic disease, of which dietary interventions are a major cornerstone. Now, I want to highlight actually a very interesting publication that came out last month. I had a chance to discuss this with some of the distinguished faculty today. As some of you may know, in 2022, the US House of Representatives passed a bipartisan resolution calling for meaningful nutrition education for medical trainees. And last year, the ACGME actually hosted a nutrition summit, convening together many nutrition science experts in the field, also with the AAMC and American Association College of Osteopathic Medicine, to discuss implementing nutrition competencies for medical students and trainees. And they actually put together 36 different nutrition competencies and advised that these competencies be included as part of licensing and board certification examinations. And as well as many of our practicing physicians and medical student trainees know, it's actually really hard to find nutrition content. We oftentimes have to go to other non-medical sources to get this information. So I think this is another reason why we really have to pay attention to the role of kidney nutrition in the management of kidney disease. I also want to highlight an article by Dr. Bautier. So he was a part of the Kidney Research National Dialogue and NIDDK group who convened together experts in the field and discussed what are the research priorities in the field of nephrology. This was published in CJSN over 10 years ago, yet at that time, they recognized that there needed to be more research on the role of obesity and diet in CKD, with a number of these areas focusing on nutritional health, such as dietary protein intake and the role of plant-based diets. So based on these observations, we had the opportunity to start a few years ago an NIH R1 funded study called the Optimal Project, which is a multidisciplinary project in which we're really focusing on the conservative and preservative care of kidney disease, trying to delay or avert the need of dialysis. We're very grateful to work with a lot of different medical centers, as well as the VA, and with support from the NIH. And in this major project, where we're looking at different retrospective and prospective approaches to try to find ways to avert or delay the need for renal replacement therapy, we've created patient toolkits. So we have late-stage CKD clinics where this funding has inspired the creation of different patient materials about their different options for late-stage CKD management, and have materials that are really based on questions that patients ask us. So I think in this, I think similar to many other, I think clinicians who I had a chance to talk with today, one of the most frequent questions we get from patients: if I have kidney disease, will I have to have dietary changes or restrictions? As part of our late stage CKD clinics, we have also created collaborations and partnerships with specialty trained kidney dietitians, in which they have the chance to see them for counseling on not only low dietary protein intake, but also guidance on plant-based protein sources, greater intake of fruits and vegetables, as well as greater consumption of dietary fiber. So I'm going to talk more about the rationale for these different approaches we're using, the science, and also clinical implementation. So in terms of the rationale for low protein diets in CKD, I would say that largely our clinical practice guidelines currently recommend some type of lower dietary protein intake in the setting of non-dialysis dependent CKD, although there are some nuances in the exact threshold of dietary protein intake. So let's take a deeper dive into this. As some of you may recall, in 2020, the National Kidney Foundation, in collaboration with the Academy of Nutrition Dietetics, released the highly anticipated update in nutrition guidelines for CKD. And there was actually a commentary on this by the International Society of Renal Nutrition and Metabolism, which is the largest global society of kidney nutrition, endorsing the recommendations from these rigorous guidelines. So what did they say in terms of dietary protein intake, in terms of the details? As background, the NKF Academy of Nutrition and Dietetics KDOKI work group largely based their recommendations on clinical trials, not observational studies. And based on this evidence, in patients with stage 3 to 5 CKD without diabetes who are metabolically stable, they recommended a lower dietary protein intake based on grade 1A evidence for reducing the risk of end-stage kidney disease and death. So more specifically, they advise a dietary protein intake of 0.55 to 0. grams per kilo per day, or even a very low protein diet of roughly 0.3 to 0.4 grams per kilo per day if taken in conjunction with keto acid analogs to be able to meet their adequate dietary protein intake. Now, with respect to CKD with diabetes, they had similar recommendations for lower dietary protein intake, although a slightly different threshold of 0.6 to 0.8 grams per kilo per day. However, this was based on opinion level evidence, not clinical trials, and we'll talk more about this evidence gap. As many of you may also recall, earlier this year, the updated CKD guidelines from KDIGO were also released. And in these guidelines, the thresholds were slightly different. They recommended a dietary protein intake in patients with CKD not on dialysis of 0.8 grams per kilo per day, irrespective of diabetes status. However, I do want to highlight in one of their practice points, they advise that in patients with CKD who are willing and able, that they could have an intake of a very low protein diet, once again of 0.3 to 0.4 grams per kilo per day, if taken under close supervision by a specialty trained dietitian or other practitioner, and in conjunction with essential amino acids or keto acid analogs to meet their protein requirements. So a little bit of difference in guidelines, and I'm sure we're going to be seeing some reports, I think, coming out in terms of trying to harmonize these slightly different recommendations to add clarity to the field. But this makes sense from a physiologic standpoint. As we know, with higher dietary protein intake, we see dilation of the afferent arterioles, glomerular hypofiltration, and increased intraglomerular pressure. Conversely, with lower dietary protein intake, we see afferent arterial vasoconstriction, decreased glomerular hypofiltration, a reduction in intraglomerular pressure, and reduced proteinuria. And as we know, glomerular hypofiltration or hypertension are two of the major risk factors for CKD progression. One of the landmark studies to highlight this was published by Dr. Kathy Tuttle and Dr. DeFronzo. So in this New England Journal of Medicine study, now almost 30, 35 years old, they studied 12 patients with diabetes and 9 patients without diabetes who underwent GFR measurement as well as renal plasma flow during an overnight fast, as well as with IV amino acid infusion. And they observed that in the fasting state, patients had normal GFR and renal plasma flow, but while undergoing the amino acid infusion, both groups had an increase in their GFR and renal plasma flow, although this was more exacerbated in patients with diabetes. So let's keep in mind this distinction in patients with diabetes with heightened GFR, heightened renal plasma flow with protein intake. Unfortunately, in the US, we see much higher amounts of dietary protein intake consumption, as well as in other developed countries. So this is cross-sectional data that was published by Dr. Linda Moore, who's the co-editor-in-chief of the NKF Journal of Renal Nutrition, that looked at a nationally representative cohort of US adults from NHANES who underwent 24-hour dietary recall. And in this study, they observed that the mean dietary protein intake of adults was higher than recommended guidelines by the Institute of Medicine for those who are healthy without CKD, and also higher than that with those with CKD based on KDOQI guidelines. And this is probably not surprising given the popularity of high protein diets in the US and developing countries. The Atkins, Paleo, South Beach, the Zone diet, and even the keto diet have become highly popularized as a means to reduce weight and as well as to mitigate diabetes. However, in the setting of CKD, we can see harmful effects with higher dietary protein intake. We'll see this glomerular hypofiltration, increased intraglomerular pressure, and damage to the glomerular structure in a vicious cycle. Therefore, low protein diets play a critical role in the management of CKD by lowering this glomerular hypofiltration and proteinuria. And there's emerging sub-analyses data actually showing that it may have synergistic effects with RAS inhibition and SGLT2 inhibitors. And hopefully maybe even some more evidence forthcoming on its role with GLP-1s and also non-steroidal MRAs. Now, there have been a number of clinical trials and meta-analyses, I think, reporting the effects of lower dietary protein intake in mitigating certain kidney disease outcomes. This was a meta-analysis of clinical trials that I had the opportunity to participate in with other, well-established investigators. And in this study, we found that compared to higher dietary protein intake of greater than or equal to 0.8 grams per kilo per day, a lower dietary protein intake was associated with a lower risk of CKD, a lower risk of death, as well as less metabolic complications. However, there were no differences observed in terms of nutritional or malnutrition indices across these lower protein versus higher dietary protein groups. Now, despite this, there's still a lot of trepidation and the ongoing question, are these dietary protein intake thresholds safe and nutritionally adequate? And I want to give a resounding yes to this. Metabolic studies have shown that in healthy adults, a dietary protein intake of about 0.46 grams per kilo per day avoids negative nitrogen balance. And to avoid falling below this threshold, the lower threshold of the dietary protein intake for CKD actually gives a 33% buffer at 0.6 grams per kilo per day. Additionally, in healthy adults, the recommended dietary allowance is actually 0.8 grams per kilo per day. So the upper bound of CKD. This is actually the estimated average need of a non-pregnant, non-lactating healthy adult that of about 0.6 grams per day, plus an additional 0.2, 33% buffer to avoid falling below this threshold. And this has been endorsed by the Food and Agricultural Organization of the United Nations, World Health Organization, also the Board of Academy and National Academy of Sciences. So in other words, the dietary protein intake thresholds recommended for metabolically stable adult CKD patients are actually pretty much the same as that of healthy adults. We just eat way too much protein in the US and other developed countries. Now, in addition to the amount of dietary protein intake, the source of protein intake is also protein. And this is where we get into the discussion of plant-based diets and their role in CKD. So there are a number of different plant-based diets that are utilized, including the Plato diet that I'll go into more detail, the DASH and Mediterranean diet, flexitarian, vegetarian, whole food, and even the vegan diet, in which not just the diet, but even the entire lifestyle is devoid of animal products. However, I want to underscore that a plant-based diet is not per se a low-protein diet. So to the left panel, this is the Adventist 2 health cohort in which they showed that the amount of dietary protein intake of a vegetarian was the same as that of a non-vegetarian. And they actually saw that strict vegetarians exceeded the recommended dietary protein intake for their population. To the right panel, we see data from the EPIC Oxford study, and they show that people who consume plant-based diets, their proportion of caloric intake from dietary protein actually exceeded the minimal threshold for US and UK guidelines. So once again, not all plant-based diets are the same, and not all plant-based diets are low-protein diets that we need for CKD. Now, additionally, the Mediterranean diets and DASH diets have known beneficial effects on reducing hypertension, diabetes risk factors, diabetes, dysglycemia, as well as cardiac risk. However, although the Mediterranean DASH diets confer a number of salutary benefits, these are not per se low-protein diets, although they can be modified to try to adjust their dietary protein intake to the amount recommended for CKD. So therefore, in our clinical practice and in our research, for example, our optimal study, we utilize something called the Plato diet, which is comprised of 0.6 to 0.8 grams, 0.6 to 0.8 grams per kilo per day, with over 50% from plant-based sources that is low in sodium, high in fiber, and with adequate caloric intake. And that most importantly is administered in conjunction with specialty trained kidney dietitians. Now, what do the guidelines currently say about plant-based diets? So once again, the KDOQI updated guidelines for nutrition were issued in 2020, now 4 years ago, and these are based on rigorous clinical trial data, not observational studies. And at that time, they advised that there was insufficient evidence to recommend a particular type of protein type, animal or plant, in stages 1 to 5 CKD. Although they did endorse the use of Mediterranean diets or fruits and vegetables for various CKD-related complications based on grade 2C evidence. But notably, the KDIGO guidelines that were issued this year actually included a practice point encouraging a higher consumption of plant-based foods as opposed to animal-based foods, and lower consumption of ultra-processed foods. I would say that even since the publication of the National Kidney Foundation Academy of Nutrition and Dietetics KDOQI guidelines, there has been more emerging data demonstrating potential benefits of plant-based diets on various outcomes, including lower risk of incident CKD and CKD progression, complications of CKD, risk factors for developing CKD in the first place, and giving some reassurance about the potential risks. So I'm just going to take you through a sampling of some representative studies to get a flavor, I think, no pun intended, of the plant-based diets. So in terms of the outcomes of CKD, what about incident CKD? So this is a study that looked at roughly 12,000 participants from the ERIC cohort who had no underlying CKD, who underwent repeated measures of food frequency questionnaires, which, as many of you may know, is a validated tool for long-term habitual intake of food, although it does have some limitations. And in this cohort that was followed for a median of 23 years, they observed that having consumption of more red and processed meat intake was associated with a higher risk of developing incident or de novo CKD, whereas greater intake of nuts, legumes, and low-fat dairy was associated with a lower risk of developing incident CKD. What about CKD progression? So while in Boston, I had the privilege of working with Dr. Gary Curhan as my Harvard School of Public Health mentor. And this was a study that they published now over 20 years ago, looking at over 1,600 participants from the nurses' health cohort. These patients were parsed in those with normal kidney function, those with mild CKD, and found that greater intake of vegetable protein was associated with more stable kidney function, whereas greater intake of non-dairy animal protein intake was associated with a higher rate of eGFR decline after an 11-year follow-up. I had the opportunity to work with a number of talented mentees outside of even nephrology, including our postdoctoral research fellow, Dr. Yoko Narasaki. She has a PhD in nutrition science and also is a clinical dietitian. And she published a study in the American Journal of Clinical Nutrition looking at the amount as well as composition of dietary protein intake in CKD patients from NHANES. And she found that both greater consumption of dietary protein intake in general, as well as high biologic value proteins. So these are proteins with an amino acid composition that is similar to human proteins that are typically coming from animal-based sources, were each associated with higher mortality risk. And actually, if you look at the older NKF KDOQI guidelines for nutrition before the update in 2020, notably, they actually recommended greater consumption of high biologic value source proteins. So this is another area in which we need more research, and also endorsing less animal protein, more vegetable type protein, and fruit-based protein intake. There's also clinical trial data showing evidence for the benefits of plant-based diets in reducing the risk of CKD and its progression. So this is a very well-cited clinical trial by Dr. Liliana Garniato's group that looked at over 207 patients with CKD without diabetes. These patients were randomized to a supplemented very low protein vegetarian diet versus a standard low protein diet. And those in the former group had a lower likelihood of developing the composite outcome of progressing to renal replacement therapy, or a more than 50% decline in GFR. So there is clinical trial data showing the benefits of plant-based diets in reducing the risk of CKD progression. However, where the evidence gap lies is actually in the setting of diabetic kidney disease. There are some pilot trials that have shown the benefits on surrogate outcomes, but as you saw from the KDOQI guidelines, a paucity of evidence informing how much and the type of dietary protein intake we endorse in diabetic kidney disease patients. So this motivated us to pursue an NIH R1 multi-center study that we started last year called the PLAFON trial, which is a plant-focused nutrition in patients with diabetes and CKD study. My co-PI and contact PI is Dr. Cam Kalantarizadeh, a kidney nutrition expert, and we're currently enrolling for this study. The goal of this project is to examine 120 patients across 2 major centers and multiple satellites among patients with CKD and diabetes who are being randomized to a plant-dominant low-protein diet or a non-plant dominant low-protein diet. And we're looking at the outcomes of dietary adherence, nutritional and body composition measures, glycemic, kidney, and safety endpoints, as well as patient-reported outcomes. So the recruitment is ongoing, and we hope to have some updated evidence and data to show you at one of our next interactions or meetings. One overarching point that I do want to highlight across all of this is the importance of collaboration with multidisciplinary stakeholders. Recently, I had the opportunity to participate in a kind of lively written debate with other experts in the field about the role or I think non-role of low protein diets in CKD. And it was a lot of fun. I think a lot of evidence brought forth from both sides, but I think one of the most important take-home messages I think that came out of this was emphasizing that collaboration with kidney dietitians further enhances the safety and adherence to low protein diets. So I have to say, I consider it standard of care to refer all of our patients with non-dialysis CKD as well as dialysis CKD to a nutrition specialist, a kidney trained nutrition specialist. And as some of you may know or may not know, it's important to recognize that Medicare actually covers 4 dietetic visits per year for CKD, not just diabetes. And so this has been published by experts in the field like Dr. Holly Kramer at Loyola University, who's also a big champion of collaboration with kidney dietitians. So I want to now talk a little bit about plant-based diets and their role in reducing the complications of CKD. So based on work by Dr. Vattier and others, we know that there are many ill effects of metabolic acidosis on kidney health outcomes, including kidney function, bone health, muscle strength, and other muscle outcomes. And we also know that animal-based proteins have a higher dietary acid load, whereas plant-based foods are acid neutral alkali producing. So I'm sure that a number of patients would be much more, I think, enthusiastic about consuming fruits and vegetables as a supplement as opposed to bicarbonate tablets, which actually in and of themselves don't confer that much alkali load. So in terms of the premise for this, animal proteins are comprised of amino acids that include methionine and cysteine, which have organic sulfur. These get oxidized to inorganic sulfate, increasing the acid load. In contrast, plant proteins may contain citrate or malate, which are natural dietary alkali, and this gets converted to bicarbonate that can mitigate metabolic acidosis. Now, there's actually been clinical trial data by Dr. Weston's group actually showing the benefits of fruits and vegetables in ameliorating metabolic acidosis. So we know that fruits and vegetables not only increase the total plasma CO2, but they also increase the net acid excretion, I think really pioneered by Dr. Battey and others. So in 2 different clinical trials, Dr. Weston's group showed that compared to placebo, fruits and vegetable intake used as a kind of alkali supplement actually improved metabolic acidosis and actually decreased the decline in GFR as compared to those who received usual care. So I think clinical data to corroborate some of these physiologic principles. Now, shifting gears to another type of common metabolic complication that we see in CKD, mineral bone disease. So this is actually one of my favorite studies among a number of important studies, I think pioneered by Dr. Isakova, in which she looked at the CRIC data showing a very high burden of mineral bone disease across the different CKD stages. And one of the important sources of exogenous phosphorus is actually dietary phosphorus intake, which typically comes in 2 main sources, organic or inorganic. So organic sources of dietary phosphorus include animal proteins in the form of caseins or plant-based proteins that are accompanied by phytates. And I had a great discussion, I think, with Dr. Kula earlier today about a recent CJSON paper by Dr. Koppel and others on the role of phytates in kidney disease that I encourage you guys to read. Now, whereas animal-based proteins having a higher phosphate bioavailability of 40 to 60%, the bioavailability of phosphorus from plant-based proteins is much less because humans do not contain the degrading enzyme phytase to, I think, degrade these phytates. As we know from, I think, work by Dr. Isakova and other, I think, MBD experts, more socioeconomically underserved patients those who suffer from disparities in social determinants of health may not always have access to fresh types of foods and may have to eat more processed foods. And these, although there are some benefits in terms of preserving, I think food flavor, moisture, and I think longevity, these additives have a very high bioavailability that may be as high as 100%. So they dominantly contribute to the high phosphorus dietary loads in our CKD and non-CKD patients. So this is a really important study that was published by Dr. Sharon Moe a number of years ago, really showing the benefits of plant versus animal type proteins and mitigating this phosphorus load. So this was a crossover trial of 9 patients in which they underwent 1 week of vegetarian diet, 1 week of an animal protein dominated diet, and notably when they were consuming the plant dominant protein, they had lower serum levels of phosphorus as well as lower levels of phosphaturia. Now, one challenge that we face with trying to read food labels and understand the effects of exogenous dietary phosphorus intake on our metabolic health is the lack of a marker for the bioavailability of phosphorus. So, once again, very privileged to work with, very talented trainees like our postdoc, Dr. Narasaki, who, while she was in Japan, conducted a study trying to develop a phosphatemic index to measure this dietary phosphate bioavailability in patients. So to the left, you can see, I think, analysis she conducted in 20 healthy patients who consumed various types of foods with the same amount of phosphorus. However, some were from animal-based sources, some were from plant-based sources. And based on this, she defined their phosphatemic index. Then after administering, I think, patients various types of foods with these differing phosphatemic indices, she found that with patients who had lower phosphatemic index food consumption, they had lower FGF23 levels as well as higher activated vitamin D levels. So I think, hopefully this is some type of tool that she can bring, I think, further into clinical practice. But, it really shows the importance of the type of protein and type of source of the food that we consume in terms of our mineral bone disease markers. I also want to say a word about dietary fiber. There has not been enough study about this in the setting of CKD and end-stage kidney disease. As we know, dietary fiber is a non-digestible form of carbohydrate that has largely been found in plant-based foods. In the non-CKD population, has been shown to have a number of benefits, such as weight loss, mitigating hypertension, improving glycemic control, addressing dyslipidemia, and even modulation of the gut microbiome. I've been very privileged to work with colleagues at the University of California, Irvine for over a decade, about 11 years, including Dr. Nick Vaziri, Dr. Wei-Ling Lau, who've done a lot of work in the area of dietary fiber and type of protein intake on the gut microbiome. And with lower fiber and higher protein intake, particularly from animal-based sources, we may see more production of P-cresol, phenols, TMA, indoxyl sulfate, things that we know have a negative cardiometabolic risk. This is animal-based data. So in my new institution, I'm really fortunate to work with my VA-GLA chair of medicine, who is a global nutrition expert. And she, with other nutrition leaders in the field, Dr. Dave Heber, and also the longstanding chief at VA-GLA before me for 30 years, Dr. Glenn Nagami, published this very interesting animal model in which they looked at CKD rats. And these rats were administered fiber and found that those who had more fiber intake had less kidney injury and fibrosis on biopsy, and they also had less production of pre-cresol sulfate. So animal model, experimental model data also endorsing, I think, the potential kidney health benefits of more of dietary fiber intake. Now, bringing this to the clinical setting has included work by Dr. Tammy Sirich and Dr. Tim Meyer's group out of Stanford and the VA Palo Alto. So they actually had a small pilot trial in which they randomized about 50 patients to a dietary fiber supplement versus a placebo, and actually found that those in the dietary fiber intake arm in dialysis had less production of these uremic toxins, which may have downstream effects on cardiometabolic health in our dialysis patients. Now, I want to spend some time talking about the practical implementation of low protein plant-based diets. And I can imagine there may be a number of questions and I think great discourse about how do we do this effectively in the CKD population. So one controversial practice that I may have, and I apologize if some people may be in disagreement, is that I avoiding heart-healthy potassium-rich foods. And I also recommend this to our nephrology trainees and fellows. As you can see from those lists, the type of foods that have the highest dietary potassium content are fruits and vegetables, things that are important for cardio, kidney, metabolic health in our kidney patients. And in fact, heart-healthy diets such as a DASH diet have a very high amount of dietary potassium content, about 4.5 grams per day, when in clinical practice, a traditional paradigm for CKD has been to recommend something less than 3 grams per day of dietary potassium intake. Our talented postdoctoral fellow Yoko had actually published 2 studies showing that what we may be doing is not well supported by evidence. There's actually been a paucity of data actually showing the benefits of lower dietary potassium intake on outcomes in the kidney disease population. In fact, a number of the studies showing the relationship between dietary potassium intake and its impact on serum levels is not rigorous or actually rather weak. So to the left, she published a study looking at data from a longitudinal NIH K24 multi-center cohort called the MADRAD study, in which dialysis patients underwent repeated food frequency questionnaires and found that patients in the lowest dietary potassium tertile had the highest mortality risk. To the right, she examined a CKD cohort out of NHANES and looked at both concurrent dietary fiber intake as well as potassium intake, and found that compared to the participants who had the highest amount of dietary potassium and fiber intake, those with lower amounts in both groups had the highest mortality risk. We also are now in an era in which we have access to new therapeutics that can actually improve our nutritional support of advanced CKD and dialysis patients. So potassiums may actually allow for liberalization of dietary potassium intake. In this era, with these potassium binders that are no longer, so novel, we can have greater dietary potassium liberalization and consumption of a heart-healthy diet, continuation of renoprotective ACEs, ARBs, and MRAs, as well as maybe even potentially avoiding or delaying the need for dialysis. And once again, I just really want to emphasize the essential role that kidney dietitians play in medical nutrition therapy. When I'm seeing my patients in my non-dialysis dependent CKD clinic, I can give them the guidelines. I can tell them, what the dietary protein intake thresholds are, and even some recommendation on the proportion of the amount of plant-based or animal-based proteins. But this has very little meaning to them. They really need to meet with a kidney dietitian that can do an assessment of the amounts and types of protein they're intaking. Maybe they're right at goal, maybe they're below threshold, maybe they're taking too much, and they can actually work with the patients to put together a food plan that makes it palatable and feasible to maintain in the long term. So, in closing, dietary interventions, including a plant dominant low protein diet, are cornerstones in the management of this cardiovascular kidney metabolic disease. And rigorous clinical practice guidelines support low dietary protein intake in CKD patients to reduce the risk of kidney disease progression and mortality. Once again, grade 1A evidence from KDOQI on reducing the risk of ESKD and death for non dialysis dependent CKD without diabetes. There's increasing evidence that plant-based diets reduce the risk of de novo CKD and CKD progression, risk factors for CKD, as well as CKD-related complications, which include metabolic acidosis, hyperphosphatemia, and minimal bone disease burden, as well as uremic toxic generation. There's also growing data that dietary fiber intake reduces uremic toxin generation and cardiometabolic risk in both CKD and non-CKD, although we need more research collectively in this area. And finally, the practical implementation of low protein plant based diets should include an individualized, personalized approach and multidisciplinary collaboration with specialty trained dietitians and close monitoring for metabolic complications and adequate dietary protein intake. And I want to pay acknowledgement to so many mentors and collaborators, through the years. This slide actually can encompass all the folks I've had the privilege of working with and learning from. I'm thankful to the NIH and other funding bodies for the support. And it really is such a privilege to see so many old friends, old teachers, and meet new friends during this visit today. So if you have any interest in any of these areas, we do have a lot of resources in our group. We're very enthusiastic about collaboration. We're working with a number of different national and international groups on different kidney nutrition studies, metabolic studies. So please don't hesitate to reach out to me if you think that there could be any fun partnership we can work on together. So thank you. Be happy to take any questions.